Bismillahirrahmanirrahim. Let's talk about hypernatremia. Okay, so hypernatremia by definition is plasma serum sodium of more than 145 millimole per liter. It's less common than hyponatremia, but it's actually as serious as hyponatremia because mortality can be up to 50%. So you're most likely you're going to see hyponatremia more commonly, but hypernatremia is still serious medical problem. And it's most common at the extreme of age, so people in pediatrics deal with it as well. Risk factors in adults include, as we said, extreme of age, so it's more common in elderly, especially if they're being hospitalized. And another common risk factor is difficulty swallowing or dysphagia. And a lot of these patients are put on thickened liquid if they have issue with or concern about aspiration. So this is really difficult situation. There's a lot of data that actually does not support the notion that thickened liquid diet can prevent aspiration. And given the fact that this kind of diet can actually cause hypernatremia, then you really have to think twice before you put your patient, especially elderly, on a thickened liquid diet. Maybe it's a better idea to have them being able to drink under supervision. History of dementia, history of CNS disease, which can lead to decreased thirst response and decreased ADH production. All these factors can really contribute to hypernatremia. As you know, whenever it comes to sodium control, it all reflects what balance of water in the body, right? So there is two important mechanisms or organs to control the water balance or water homeostasis, and these are the neuronal mechanisms, the brain and the central nervous system and the peripheral nervous system, and the renal mechanism of the renal system. So thirst is very important. There are many centers or neurons involved in the control of thirst, including neurons in the thalamus, hypothalamus, and the cortex. And you really need an intact thirst mechanism to be able to maintain water homeostasis, and also you need to have free access to water to kind of prevent the development of hypernatremia. So thirst is really important. And then the release of ADH and ADH synthesis, which is synthesized in the posterior hypothalamus, and then this hormone gets stored in the posterior pituitary. So any disease in these two organs can also affect the water and sodium homeostasis. And also it's very important for the control of water balance is osmoreceptors, which is mainly found in the anterior hypothalamus, and these osmoreceptors can sense the change in the serum osmolality. And then the other important organ is the kidney, of course. So many factors contribute to the development of hypernatremia, including the rate of sodium reabsorption, which happens mostly in the proximal convoluted tubule. And also important is the strength of the medullary gradient in the kidney, in the medulla. If you remember from the basic physiology, really the work of ADH depends on the gradient, osmolality gradient, between the tubule and the interstitium, and that's the force that drives water through the aquaporins when they get opened by the ADH activity, and water will be able to move from the area of low concentration to the area of high osmolality or high concentration. So any problem with the kidney also can affect the renal and the sodium and water homeostasis, and that's manifested mostly by the diabetes insipidus, nephrogenic diabetes insipidus, which is not a topic that we're going to discuss this video. We're going to discuss in another video. Okay, regarding the causes of hypernatremia, just like most of the conditions associated with something being low or being high. There's something lost, or there's a shift of that element from compartment to compartment, or there's something else being added. So in case of hypernatremia, there's three main mechanisms. One or two is more common than the third. The common one are the poor access to water and water loss being more than sodium loss. The third, but the least common cause of hypernatremia is salt or sodium excess. So when it comes to poor access to water, it's relatively common. It can be due to impaired thirst mechanism. This is known as hypodipsic hypernatremia. Hypo meaning low, dipsic for thirst. So there's decrease in the sensation of thirst, and that can be due to many factors, including advanced age or CNS disease. And also lack of access to water. We talked about patients who are elderly, specifically who are admitted, and there's some concern for aspiration, and they're being put on under thickened liquid diet. So unfortunately, this patient, no one will give them water because this is an order of the physician. So they can't really get water, and they can easily develop hypernatremia. So this is really important, so be mindful of that. And then if there's volume loss, especially if there's water loss more than salt or sodium loss, then hypernatremia develop, because loss of salts more than water can give you hyponatremia, which we talked about in another video. So the water loss can happen in the kidneys, and this is known as water diuresis, and this is basically diabetes insipidus. Again, we're not going to talk about this in this video. And then there is GI loss, which can happen from diarrhea if the diarrhea is associated with a low electrolytes content. Now, some patients with diarrhea can develop hyponatremia, right? So what's the difference? It depends on the content of the diarrhea. So for example, diarrhea due to viral gastroenteritis, which is relatively common, they usually have low electrolyte content. So the water loss is more than the sodium loss. And also osmotic diarrhea, like diarrhea due to lactulose, excessive lactulose, or milk of magnesia, or lactase deficiency, or gluten intolerance. These can also be associated with low electrolytes content generally, and so the water loss is more than sodium loss again, and these people can develop hypernatremia rather than hyponatremia. And then there is other route for loss, which is non-renal non-GI loss, which is basically from the skin due to insensible skin losses. A little bit less common. It can happen with excessive heat, excessive exercise, or in patients who are on mechanical ventilation. And then the third and least common is salt excess, but it still does happen. So if you give too much excessive hypertonic saline when you're treating hyponatremia, you can actually cause hypernatremia. Hypertonic total parenteral nutrition, or TPN, also can cause hypernatremia, or saline enemas for patients with constipation or other GI diseases. And then another mild or a cause of mild hypernatremia is primary hyperaldosteronism. It used to be known as Cohn syndrome. So just be mindful if you see a patient with mild hypernatremia and hypertension and maybe hypokalemia, but these are not really classic or present in all the patients. And again, if the patient has intact thirst mechanism and they have access to water, they are almost very rare, if ever, to develop hypernatremia. These two mechanisms can actually prevent a normal person from developing hypernatremia, even if they have these other diseases. When it comes to the clinical features of hypernatremia, most of the time, most of the patients that you will see especially in the inpatient setting, the hospital, they will have probably mild hypernatremia, and they might not have very much of symptoms. They might have symptoms from the other underlying disease that they're being admitted for, but unless hypernatremia is severe or acute, then the manifestations can be very subtle and very vague. So be mindful. But an important entity that you need to be aware of is hypovolemic hypernatremia. So basically, these are the patients who are hemodynamically unstable. There is loss of volume in addition to the loss of water. So there is a volume depletion and there is secondary hyperaldosteronism to compensate. So this patient might be, again, hemodynamically unstable. They might be tachycardic. They might have hypotension or postural hypotension. And the labs might show features of hemoconcentration like hematocrit increase, acute kidney injury or AKI, or increased BUN creatinine. Also, hemoconcentration will lead to hyperuricemia, or maybe decreased potassium. So these are the sick patients, and the management is really different in these situations because you need to kind of restore the volume first before you restore the water. So volume takes priority, circulation takes priority. So you usually with hypernatremia we give back water, we replace water. But when there's hypovolemic hypernatremia, you have to give volume. So you have to give them not hypotonic solution, but isotonic solution like normal saline initially to resuscitate them and maintain their blood pressure and circulation. So that's really important. So this is the first entity, clinical entity of hypernatremia. And then there's vague, non-specific neuromuscular manifestations, and these are usually due to cellular shrinkage. So remember when there's hypernatremia, increased sodium in the plasma or interstitium, what will happen from inside the cell is water will move across the gradient because most of the cellular membranes are actually they can transmit water. So water will move from the high water content to the low water content, or a low osmolality to the high osmolality. So water will move from the inside of the cell to the interstitium, and then from the interstitium to the plasma to try to decrease the concentration of the sodium in the plasma and interstitium. So that unfortunately will lead to shrinkage of the cell, any cell. Most of the cell. We know that 60% of our body is water, so water is ubiquitous. It's widespread in our body. So when there is movement of water from the inside to the outside, there is shrinkage. Now the cell will try to compensate, because the cell doesn't like that. So what will happen is the cell will try to increase a production of some osmolyte. So within minutes, it will attempt to kind of bring in sodium, potassium, and chloride to the inside to increase the osmolarity, so that water hopefully will follow and come back. After, if hypernatremia persists after hours or days, then there will be increase of the production of other osmolyte like sorbitol, betaine, and taurine. We talked about this in the hyponatremia video, and these all are attempts, but it's not going to solve the whole problem, but it's like a compensatory mechanism that can happen. So the cellular shrinkage really, or the decrease in the cell volume is really what causing most of the symptoms associated, or neuromuscular symptoms associated with hypernatremia. So this patient can again have non-specific manifestations, and it's usually more obvious if again the hypernatremia is acute or severe. So patient might have some GI symptoms like loss of appetite, anorexia, nausea, vomiting, just looking tired, lethargic, maybe irritable, weak, like generalized weakness rather than focal weakness. There might be some neurological manifestation, especially if it's severe, in terms of increased tone and increased reflexes, and maybe myoclonus as well. And then in severe cases, there might be like hyperthermia or increased temperature. I remember in pediatrics, there used to be like the entity of dehydration fever. It's not very common, and unless really dehydration is severe, you're not going to see that quite often. But it's it's a possibility. A patient might be confused. They might have delirium. Unfortunately, they might have seizures and even coma if it's really severe, specifically more than 160. And then you need to act really quickly and identify the cause and support the patient. Complications that you have to keep in mind in patients with severe hypernatremia So neurological manifestations, the first problem is bleeding, intracerebral bleed. Can be in the form of subarachnoid hemorrhage or even subdural hematoma, and that's again because of the shrinkage of the brain. So that can lead to destruction of the bridging veins because of shrinkage, loss of volume, and pulling of some of these blood vessels and bleeding. So be mindful if your patients start to develop neurological manifestations. And then also if they start to have bad headache or again another neurological manifestation, this could be due to cerebral venous thrombosis, and they might need an MRV to check for that. And this is also because of the severe increase in the osmolality. And then last one is rhabdomyolysis. Shrinkage of the cell, of the muscle cell, can lead to lysis of these muscle cells and all the other complications and electrolyte disturbances and AKI, acute kidney injury, associated with rhabdomyolysis. So these are the complications that you need to look at. These usually happen in patients in the ICU. They have like really severe hyponatremia. They're being admitted to the ICU. You need to be mindful and do frequent neurological examination, keeping in mind these possibilities. When it comes to the labs in hypernatremia, it's really straightforward, right? I mean, you check the serum sodium, you get hypernatremia, but the labs is kind of to help you determine the cause if the cause is not very clear. Again, most of the time you kind of have an idea why the patient is hypernatremic. The classic example: elderly patient with dementia, risk for aspiration. Again, they have been put on thickened liquid, and then you start to see increase in the sodium when you do the serum sodium with labs. So in that case, what's causing it. It's like iatrogenic. You are the cause of it, so you have to address it. But sometimes, if the cause is not very clear, then you need to kind of look into the lab and see how you can figure that out. So again, serum osmolality should always be high, with hypernatremia, because sodium is a major determinant of the osmolality in the extracellular fluid. So it's always high. And then an important lab findings that you have to think about is, if your patient is having normal kidney function and they're having hypernatremia from any cause, then there's really three things that normally will happen by the body to kind of minimize the problem. So the first one is a decreased urine output. So this patient, because of dehydration and decrease in the water, the body will try to maintain water, so it will the kidney will attempt to retain water by decreasing the urine output. So that could be a normal response from the kidney, decreased urine output. And then also that urine will be concentrated, so urine will be less, osmolality concentration will be more, and you can check that by urine osmolality, or even simpler by the urine specific gravity, which is done by the urine analysis. So specific gravity should be high, and then of course the urine osmolality should be high too. These two usually correlate, so one might be enough. So if you see the three, then maybe the kidney recognize there's a problem with water and it's trying to reserve water. So this is a normal response. Now, if you see something different, if you see polyuria, the urine output is not small. Actually, the patient is having more than 2.5 or even 3 liters or more of urine output, and the urine osmolality is not high, it's actually low. Okay, that's abnormal. There's something going on. This is just too much water, and this water is going through. It's going to like a siphon, basically, right? So this is what diabetes is. So diabetes basically literally means siphon. There's a lot of water going out. This water can be sweet, and this is diabetes mellitus. And patient with diabetes mellitus, they have hyperglycemia, they can have increased urine output, and in that situation, they can have hypernatremia as well. Or that urine can be tasteless, which is the definition of diabetes insipidus. Insipidus means tasteless, basically. So if you want, you can test the urine. No, don't do that. I'm just kidding. I mean, it used to be a bedside test in the old days, but not anymore. Thank God we have more simpler tests now. But basically, this is, if you see something different than the three normal responses from the kidney, then you have to think about, diabetes insipidus, diabetes mellitus. Again, we're not going to talk about DI in this video. And then, if you're suspecting DI, then you can do the water deprivation test. Also, again, we're going to talk about that when we talk about diabetes insipidus.